A very good afternoon to everybody. On behalf of the organizing committee of IAPCON 2022, I welcome each of you for this scintillating and mind-titillating debate session. For this session, we have 4 esteemed judges on the panel who will be assessing the debaters. First, we have Dr. Daniel Mundai. He's a professor at the National Academy of Medical Sciences in Nepal. Dr. Edishari Divakaran, who's the director of Institute of Palliative Medicine, Kerala. Dr. Rumana Dola, she's a consultant in palliative medicine and chairperson of the Bangladesh Hospice and Palliative Medicine. Dr. Punita Lal, who's a professor of radiation oncology, SGPGI, Lucknow. Before we start the session, we'll have some ground rules for the debaters and for the judges. One of our speakers, Dr. Chaitanya, is down with COVID, unfortunately, and he messaged me today morning, and he's having symptomatic COVID, so he's not able to participate. So we will have 9 participants, 5 and 4. Now the rules are, each participant will be given 5 minutes to rest their case. At exactly 5 minutes, we will mute the participant. So me or Dr. Jyotsna, who are the moderators, will mute the participants automatically for want of time and the constraints. You'll be scored on a total score of 30, and there will be a negative mark against your scoring. The last question will be a penalty question, which the judges will decide if the person has had a poor code of conduct, and he will be automatically given a negative mark by the judges. The judges will provide an unbiased judgment without discussing with each other. In case of a tie, what we will be doing is the final scores will be then discussed. The moderators, me and Dr. Jyotsna, will be discussing with the judges as to who they feel have performed better and why do they feel so. This is being done for want of time because we have exactly 1 hour to finish and we can't kind of restart the session. So we'll be discussing with the judges, and 3 consensus decision out of 4 will be considered as final, and the participant will be selected as the winner. So we'll be having 2 winners. One is 2 winners to this session. Now, without much ado, I would like to now call upon Dr. Prasoon from Mumbai, who will be talking for retaining the name, who will be talking against retaining the name palliative medicine. Dr. Prasoon, are you there?
Yes, sir.
Yeah. Thank you, Dr. Prasoon.
Thank you.
Go
sir.
ahead.
Good afternoon, honorable adjudicators, colleagues, and audience. I will take the next 5 minutes to put forth my views and reasonings for being affirmative to the motion of changing the name palliative care. I look really not to persuade you, but to remind you what you already know to be true. Access to palliative care is considered as a human right, and there is indubitable evidence of its benefit in multiple domains to patients and caregivers. Despite this, Gaitar et al. Could identify barriers to its access from global, social, organizational, and individual perspectives. It hurts me as a specialist palliative care provider when I go through the WHO updated key facts on palliative care. Worldwide, out of the 78 million needy, only 14% of the people receive it. 2 out of 7 major barriers projected by WHO are lack of awareness among the policymakers, healthcare professionals, and public about what palliative care is, and the misconceptions about palliative care that it is only for cancer or for end of life. Corroborating to this is the randomized trial of language. Does it matter what you call it? He observed that with patients with cancer reported the term supportive care to be better understood, having a more favorable impression and more likely to be something that they would want in future when contrasted with the name palliative care. The name impact of medical colleagues as well. Fadul et al. From MD Anderson did an interesting survey of 140 medical oncologists about their perspectives of the name palliative care and supportive care. When they were asked, would I use this service for a patient with symptoms in new diagnosis, curative treatment, advanced disease, and end of life? He found that there was a significantly less interest in the service when it was called palliative care, but this evened out at end of life. The same survey could also identify that medical oncologists perceive the name as a barrier to their referral and one from a volunteer who had worked in this hospital for 15 years, who told me, "Why have you come to see me? I am not yet palliative." I assume something similar would have been encountered by you at some point of time. Now that we know from evidence and personal experience that name is a barrier, what can be done? So evidence to this comes again from MD Anderson, where in 2007, they changed the name from palliative care to supportive care without any campaign to re-educate or redefine the term. What Shalini Dalal and team could found as an impact of this was doubling of the inpatient referrals and significantly greater and earlier reference to outpatient clinic at 1 year. Let us remember that back in 1970s, Professor Belfort Mount coined the term palliative care to prevent the confusion and any negative connotation associated with the word hospice so that cancer patients approaching end of home. The scope of palliative care has changed over the years to include malignant diseases and in a variety of settings. Definitions have been changing since then, as Hui et al. In his systematic review could find 24 definitions to palliative care till 2011, and it continues to increase. Unfortunately, the perceptions are not at all changing at the same pace as the definitions. So, my reasoning is simple. We know our involvement is beneficial. The name is one barrier, and when the name is changed, we have some evidence to suggest that it leads to greater involvement of our services. It could be argued that these are single institutional studies, but I want to focus on how a small investment of name change could greatly be influential. Finally, the right choice here is to put aside our pride and inertia in our emotions and really make the decision that is best for our patients. I would like to conclude by reminding that any name change would have to be accompanied by an improvement in scope and culture. Thank you.
Thank you, Dr. Prasoon, for an excellent elaboration. Right now, I'll call upon Dr. Jyoti Prakash, who will be talking against changing the name palliative medicine. Dr. Jyoti Prakash, over to you, please.
Yes. Thank you so much, Dr. Srikanth. And good afternoon, everyone, to all the colleagues and the respected judges and our other participants who are logged into this session. So, very nice presentation and a very brief and very precise point made by the speaker before me, Dr. Prasoon. However, I would like to very politely and humbly beg to differ from the stand that the need of palliative care needs to be changed to palliative medicine. Why? Why? Because I would like to request everyone to recall about the basic definition of health that we had started when we started our medical education during MBBS days. Health has been defined by WHO as not only the mere absence of disease or infirmity, but the complete physical, mental, social, and even spiritual well-being. And as palliative care physicians, it is most often than not, we tend to receive patients for whom intent of treatment is no longer curative. Even though we receive many patients in the early part of the referral system also, where we undertake symptomatic management. So when the patient is no longer being offered a curative intent, and our role is to provide symptomatic management, supportive care, like Dr. Prasoon was saying, best supportive care. Palliative care definitely has a role to play, and it is provided ideally by a team of support providers. Many of the advanced centers who have the privilege of having worked with a team and which I am also trying to replicate in my current practice also. So it involves the team of the physician, the primary, who is the leader of the team leader, who is most often a doctor with say basic qualifications of MBBS, MD, and further training in palliative medicine or palliative care. And he is assisted more often, he or she is assisted more often than not by a dedicated team of nursing staff who have received dedicated or specialized postings and training under the supervision of a senior nursing staff on providing palliative nursing services. Similarly, other support staff are very essential, which I have seen play a role and greatly and vastly improve the outcome of the patient. And the team which do play a role, which are often important and are often neglected, or maybe because of lack of resources, we are not able to include them on the team. They are mostly our support staff in the form of our nursing counselors, in the form of our social workers, our pharmacists, our dressers, even our nutritional support providers and physiotherapists. So this team unit comes along, they provide a 360-degree holistic support that at the end improves the overall outcome of the patient's care and improve the quality of his life. End result is that quality of life improves. We doctors, by prescribing modern medicine, play a key role, but I would rather say a very small role. Majority of the time is dedicated and spent by our nursing staff who take care of the patient's nursing needs, and they provide the adequate care that is needed. The team of physiotherapists who provide the edema care, mobilize the patient, provide specialized end-of-life care, prevent bed sore management, and those very important aspects on which the role of the ancillary care is as important as providing medications to prevent healing of the ulcers or to prevent infection of the ulcers, chronic ulcers. Similarly, the clinical dietitians, nutritionists, they, apart from the clinical dietary supplements that we as doctors advise, they also go to the extent of assessing the proper dietary needs of the patient, identifying the calorie requirement, and ensure that the patient is not in a negative catabolic state and the patient continues to have adequate nutrition even though the patient's limited intake, oral intake is limited, the patient's mobility is impaired, and the patient in general is not in a good condition. So with the help of this ancillary support system, we are able to ensure that the patient's quality of life is improved. Not only that, a few centers which have the privilege of having social workers, they ensure that the patient's other needs are fulfilled in the form of ensuring that adequate finance and the treatment costs are met. The patient, if they have any social issues, they are addressed by the social workers. Many places, the social workers arrange for fundings also.
So Dr. Jyoti Prakash, you finished 5 minutes. I move on to the next speaker, Dr. Somnath, who will be speaking for change of the name palliative medicine. Dr. Somnath. Dr. Somnath.
Sir, you're muted.
Oh. Can you hear me now?
So I hope time starts now.
Yeah, Dr. Shobnath, please go ahead.
Yeah, when it comes to any branch in medical science across the country, it has a uniform name. Say it for cardiology, neurology, nephrology, everywhere. But when it comes to our specialty, the name changes across the regions and varies with the institutions. Take for example, starting from North India, somewhere it is anesthesia and palliative medicine, somewhere it is onco-anesthesia and palliative medicine. When it moves to the Purvanchal, name changes to pain and palliative medicine. In Central India, it becomes palliative oncology. When it moves to the Western India, it becomes palliative care medicine. Somewhere it is anesthesia, critical care, and pain. When it moves to the South India, so it's become palliative and supportive care medicine. When it becomes Extreme South, it becomes only palliative care. When it moves to the Eastern India, it is psycho-oncology and palliative care. And eventually, when the patient goes to the corporate, it simply becomes pain medicine or pain clinic. So a few years ago, one of my patients has asked me simple questions which gave me a goosebump. Is it care? Is it support? Is it medicine? It is only for pain, or is a mixture of all? So finally, I realized certainly the name has an impact, which should be much simple, less confusing to the beneficiaries and more appealing. Our specialty is one of the very emerging and complex subject in medical science, but we have simplified and paraphrased the name as the way we need it in the country. So no one can deny that this diversity does exist, and which causes confusion and distress to the patients. IAPC has moved to this 29th year. It is worth having this debate and high time to change the uniform name across the country. I am Dr. Somnath from Tata Memorial Center, Varanasi. Now it comes, why do I think about change? There is enough evidence to support that the term palliation has created a negative impact on patient life, reducing the hope for the patient and their families, which causes the hindrance to them for early reporting and receiving a much needed services. Evidence also proved that the term palliative care remains synonymous with end of life care, which is significant barrier for early patient referral, which is why till date there is only a handful of well-structured RCT in this specialty. Due to the time of first referral or first consultations to the time of death duration is very short. A well-structured phase 3 RCT is required for adequate sample size, need to apply proper randomizations and blinding principle of research, required a long-term follow-up period to generate data on impact of intervention. How come we do an intervention study if we get a patient who has a shorter life expectancy, say 2 months or 3 months? Is it ethically correct? No. So where we are heading without a proper research in medicine? Are we really progressing? So to one-stop solution for this problem is early referral and patient compliance. That comes when patients and families at their best at the beginning of the disease process. I am not alone. Whole world is talking for a change. Around 19 years ago, in 2003, European Society of Medical Oncology was pioneered to take a stand and incorporate the term supportive care at their policy. And 13 years ago, 2009, MD Anderson Cancer Center also proposed the name to change it to palliative care, a supportive care, and they changed it. And 2 years later, 2011, the same institute published a study and which showed the impact of changing the name eventually increased the 41% of consultations. In 2016, 2 Canadian studies published also showed the similar impact of changing the names helps in early referral, better patient compliance, good impact of quality of life, more effective way of treatment delivery, and to generate enough data on research. In 2020, the Canada-based organizations, Multinational Association of Supportive Care in Cancer, published an article which advocated the promotion of evidence-based palliative care in the future policy. So, considering all these facts and evidence, there should be uniformity in the name, which must include the 3 terminology. According to me, first is medicine. There is no doubt that as it is a branch of medicine, it will only progress based on evidence, and we must encourage for that. Second is support. The name itself has a much appeal and a better penetration to every common people without any ambiguity. It includes all aspects like physical, social, psychological, spiritual that anyone needs at any stage of this life or disease. And third is care, because we are dealing with a disease which certainly can be completely cured. So care beyond cure should be our tagline. Both care and support have no boundaries. It can be delivered by anyone to anybody at any point of time. So it eventually helps to respect our team members like nurse, psychologist, play therapist, and medical social worker. So my proposed name should be supportive care medicine instead of palliative medicine.
Thank you, Somnath. This debate is unrolling very brilliantly. The next speaker is speaker number 8, Dr. Mansi. She will be speaking against name change. Dr. Mansi, are you there?
Yes.
Yeah, you can start now.
Thank you. A very good afternoon to one and all. Today I will be speaking on why we don't need to change the name of our branch from palliative care or medicine to anything else. I will start with a small story. Anxiety once went to God and said, "God, can you change my name?" On being asked why, she replied, "People think I'm unpleasant. Some fear me and some don't want me." On hearing this, God replied, "My dear, it's not your name that worries people. It's the emotion of being anxious that they don't want to feel. It's the uneasiness of the unknown that they're afraid of. What you could do instead is remind them that anxiety also invokes the strength in them to face whatever lies ahead." I feel same is the case with palliative care. It's not the term, but the association that people have with the term that has led us to this question of name change. Let's look at this in 2 ways. What does palliative mean to our patients? We live in a country where majority of our patients do not use English as their first language. This is true for many other countries worldwide. Many may not have heard the term palliative before being diagnosed with cancer or a chronic illness. When patients come to our department, we often first need to explain why they are being referred there. Those that don't necessarily know us as palliative medicine OPD. Many at PMH know us as OPD 75, many as the department you go to when the IV chemo stops. So renaming the branch will not really change anything for those who are unfamiliar with the term. In the case of many who do visit the department once or repeatedly, they begin to look at the department as a place of pain relief, symptom management, a place to vent their feelings, communicate their fears, liaison with local clinicians, get directions on what happens next, a place to bring their suffering children to, a place for monetary social support, and a place for them. Then why change the name for those who do understand the meaning? A scoping review of public perceptions by Grant et al. Found that 66 to 71% people had no awareness of the term palliative care. And in the same study, after being prompted with a tested definition of palliative care, 95% people rated it favorably. What a great opportunity this is for educating the masses. Now coming to our second point, what does palliative mean to other physicians? This is another massive opportunity where we can not change the term, but the perception of physicians towards our branch, be it oncologists, non-oncologists, or anyone supporting people with chronic illness. If they associate the term palliative with only end-of-life care or hospice care or non-curative intent care, it is on us to remind them that palliation covers an entire spectrum of care as defined by the WHO as an approach to improve quality of life of patients and their families facing problems associated with life-threatening and life-limiting illness through the prevention and relief of suffering by early identification, impeccable assessment, and treatment of pain and all other problems, physical, psychosocial, spiritual, emotional. Multiple RCTs, Dr. Temel, the Enable 3 studies have shown the role of palliative care in the early integration and the improvement in quality of life of patients because of palliative care. And that is why Balfour Mount had coined this term to highlight its appropriateness and its requirement at every or any stage of illness of a disease. Thomas LeBlanc writes, rebranding the term palliative care may create a favorable environment for referrals, but this approach will not address any misconceptions. Fadul and Macias suggest that perceptions of palliative care has more to do with the timing of patient referrals and not the name change itself. Bendit et al. Says rotations in palliative care during early medical training is one way of increasing awareness among medical professions. An interesting tweet by Jay Rubinstein said, associating the term with palliative care or palliative medicine with death is like conflating the scary thing with something that can actually help with the scary thing. So renaming palliative care will just lead to a new term being associated with death rather than changing the perceptions of people around this. What we need is the change of perception, how cancer became curable, how polio became a vaccinatable disease. This is what we need to bring meaning to the name palliative care. Why don't we as palliative care physicians spend our time instead of changing the name, but changing the meaning of our branch towards patient-centered care, well-being, comfort, dignity at all stages of life, all stages of death and beyond. Thank you.
We are now faced with a conundrum, isn't it? So next on stage, we have speaker number 5, Dr. Sarita, speaking for name change. Dr. Sarita, please take over.
Good afternoon, everyone, respected judges. And first, I would like to thank the organizing committee who has given me this opportunity to speak on this very important and controversial topic. Is their name should be changed or not? I want to share my experience. I am also onco-anesthetist. When I asked my onco-surgeon, why not you are referring the patient when you are making the diagnosis of the cancer? Because early integration of the palliative care is very much beneficial for the patients as well as for their family and for doctors also. So he said to me, why I send the patient in palliative care who are curable? So after listening his words, this point came in my mind. If I would say that send the patient in palliative care for the symptoms or the supportive care, like when the patient comes to know that he or she is having cancer, the whole psychology of the patient and their family caregiver is changed. So why not we are integrating the psychological support to that patients for the benefit of their treatment and their well-being. So that's why I thought that name should be changed, because name is the big hindrance to understanding that palliative care is that portion when we send the patient when the patient comes in last stage. when the patient comes in the stage 4 or incurable. So to prove in my view, there are studies also who has shows this study has published in the journal Cancer, who studied among 200 people who were responding to the referral patients. But the author found that the response of the patients of the referral who were came with the name of the supportive care, they were responded early as compared to the patients who came with the referral of the palliative care, with the name of the palliative care. So in my view, the name should be changed for the benefit of the patients. I don't think that these studies are enough to change the name, but there should be a lot of work done in this field. The name should be changed because name is the hindrance of the patient for their improvement in their life, quality of life, and the treatment. Thank you.
Ma'am, so the next speaker in line was supposed to be Dr. Chaitanya. He's not able to join us because of health issues. We'll move on to the next speaker. It is Dr. Raghav, speaker 2. He's speaking for name change. Judges, please nod. Dr. Raghav speaking. Raghav, your time starts now.
A very good afternoon to all. Myself, Dr. Raghav Gupta from AIIMS New Delhi, would be speaking today for the motion on the topic, should we change the name of a specialty? Years back, William Shakespeare used the idiom, what's in a name, in a play, Romeo and Juliet, written by him. But this proposition does not hold true when it comes to naming of specialty as important as palliative care. The World Health Organization and recently International Association of Hospice and Palliative Care have defined it as an approach which improves the quality of life of the patients and their family members when faced with the challenges of a life-threatening illness. It strives for early identification, impeccable assessment, and treatment of problems at various levels, be it physical, psychological, social, or spiritual. Even though it makes no mention of restriction during the final end days of the life, yet unfortunately, that is what it has come to be associated with. There is an image problem. It is often misperceived as the end of the life for the patient and the care team members. The term has become synonymous with dying, loss of hope, and abandonment. Because of this cloud of darkness, misunderstanding, and the stigma which is associated with the term itself, we are doing a great disservice to the mankind, the patient, and their family members. In a landmark study conducted in 2009 at MD Anderson Cancer Center in Houston, USA, they showed that primary healthcare providers and the oncologists preferred the term supportive care over the palliative care and stated that there was a greater likelihood to refer the patients early if the service was named supportive care. They stated what was the reason behind their logic behind was that the palliative term is associated with distress and hopelessness in the patient and the family members. It creates a lot of anxiety. Since our childhood, teachers and parents have always told us that first impression is the last impression. It holds absolutely true over here. One of the solutions for the conundrum we are facing right now is that we should rebrand by changing the name of the specialty. Stan Richards, a doyen of the advertisement industry, once said that strong brand is a safe place for the customers. A strong brand name should incorporate 4 characteristics. It should be distinctive, it should be relevant, it should be flexible, and it should be memorable. Now, where does the palliative care stand on these 4 parameters? The term palliative care does not convey the nature of the service we are providing, nor the benefit to the patients it is giving. So it fails the test of the relevance. Also, it does not pass the test for memorability, as it is not easily understood, pronounced, or recalled by any one of the patients and the other specialty members. So, I propose that names such as supportive care can ease the path for the clinicians who are discussing the service with the patient and the caregivers. Better branding in the form of name change would promote earlier and greater use of this essential branch of medicine. This would improve the quality of life, decrease the anxiety and depression scores, reduce the symptom burden, increase the patient satisfaction, decrease the overall healthcare costs, and at times even prolong the survival. So in the end, I would rest my case by saying that timely and quality supportive care is a right of every patient and not just the privilege. It should be a rule and not the exception. Thank you.
Thank you, Dr. Raghav. So, folks, this is the annual IAPC debate. And next on stage, we have speaker number 9, Dr. Kritika, speaking against name change. Dr. Kritika, your time starts now.
Good afternoon. Thank you for this opportunity. I'm Dr. Kritika Rao, speaking on what's in a name. Should we change the name of our specialty, palliative care? I begin with this quote: "A rose by any other name would smell just as sweet." A quote from Romeo and Juliet, a famous play by William Shakespeare. Oh, sorry, William Shakespeare. The name does matter, doesn't it? So will calling the rose a lily solve our issues? Will it cease to have its thorns? I refer to the persistent argument that we need to change the name of palliative care to supportive care due to the stigma associated with the term with death and dying, which is perceived as a barrier for timely referral and poor access to its full benefits. I think palliative care might have an image problem and not branding. Palliative care specialists are likely to be called when death is imminent, so many worry calling in earlier will increase anxiety and fear amongst patients and families. The resistance to palliative care is ultimately rooted in our collective denial of our mortality. If only changing the name could have cleared problems, we would have called the COVID a cold flu, but that may not help. As palliative care has received negative connotations over the years, changing its name would probably receive similar flack in the future. Palliative care evolved as an interdisciplinary medical caregiving approach into a medical subspecialty to provide a person-centered, holistic care optimizing quality of life and mitigating suffering among people with serious complex illnesses. And supportive care services, as MASS defines, it was developed recently to combat the cancer treatment-related toxicities. It encompasses even cancer rehab, cancer survivorship, and beyond. David Hui, in 2013, in his article to identify the definitions of various terms, also laid out a conceptual framework where he said supportive care provision was essential from the time of cancer diagnosis and during active treatment, whereas palliative care role increased and was more needed as disease progressed towards end of life and into bereavement along the continuum of the illness. So historically, palliative care derived from the Latin root palliare, or to cloak, got its start as a hospice care, often earlier delivered by caregivers at religious institutions. Later, physician Mount Balfour started the first palliative care unit in 1974. Over the years, being renamed as supportive care services in certain institutions, and more recently being called as quality of life services. However, retaining its unique identity, palliative care forms an integral part under the umbrella of supportive care. So why rebrand it? Changing the name of palliative care to supportive care, as a study suggests, may definitely increase referrals, but quite likely might confuse the beneficiaries or could also dilute the ethos of palliative care. I come back to the fact that we do not solely deal with cancer. The COVID-19 pandemic was the best marketing campaign that palliative care could have asked for, bringing in the human side of medicine. Yet because of the pandemic, the palliative care doctors believe that they have an opportunity to redefine what they do and demonstrate its value to patients in need. As a systemic review mentioned by my friends earlier, which was published in the Journal of Palliative Medicine a year ago, which looked at public perception of palliative care, where 70% did not know about it, but when prompted with the definition, more than 95% rated it favorably, which prompts as the lack of knowledge and awareness was the major reason for poor palliative care access. I would not be surprised if similar findings were to be seen in India. If palliative care is viewed as an essential evidence-based component of advanced disease management, it would no longer be chosen. It would simply be integrated by incorporating its principles and services into all aspects of care. Maybe we should be able to address the elephant in the room, that is to bring about a change in the attitude and perceptions. Instead of naming the rose a lily, let's address its thorns. Thank you.
Thank you, Dr. Kritika. So this debate is taking us to cloud nine, I guess. Next, we have speaker number 3, Dr. Rutula on stage, speaking for name change. Dr. Rutula, your time starts now.
Good afternoon, everyone. I am Dr. Rutula from Bharati Vidyapeeth. I'll be speaking for the change of name for palliative medicine. So let's just ask you, what do you do when you have a doubt or a query? Well, I, for one, generally do a Google search, and I'm sure that you guys must have done that too. So speaking statistically, there are about 2 trillion Google searches per year, which accounts for more than 90% of the worldwide search market. And on an average, a person does 3 to 4 Google searches per day. So according to Google, the first thing that pops up when you search, let's say, neurology, is the branch of medicine or biology that deals with the anatomy, functions, and disorders of nerves and nervous systems. Now let's guess what pops up when you type in palliative care. It actually is relieving pain without dealing with the cause of the condition. Well, that doesn't sound right, does it? Pashana in 2008 found in a study that there are around 37 definitions of palliative care in English and around 26 definitions in German language. But a study by Yue et al. In 2013 showed that there are around actually 24 definitions of palliative care. Now, well, a common man is not going to go and search for a scientific definition. He's just going to look at what pops up first in his Google search. And as my colleagues have previously stated, the term palliative care has been associated with a lot of stigma, and there are many barriers to the referrals for these services. Common barriers which were identified were professional barriers like lack of knowledge, the attitudes of the healthcare professionals, beliefs of the professionals, or the experience or their experiences with palliative care services. Those studies have shown that these were improved by educating the professionals. They are not completely gone. And though palliative care is not solely associated with end-of-life care, this is the area where specific barriers are particularly existing. Feig and Elibari in 2005 identified specific barriers, them being reluctance of the healthcare professionals to refer to palliative care, the lack of availability or sustainability of an hospice care, and association of hospice care with death. Speaking personally also, one of the senior oncologists in my hospital stated that she does not personally like the term palliative care and would prefer it to be called supportive care because it encompasses so much more than just end-of-life care. Gott et al. In 2011 also observed that the treating or the clinical team also lacked a consensus for the time of referral to palliative care services, which focused on the goals that we have. And as previously stated, the scope of palliative care has changed drastically in the last couple of years, which now includes non-malignant diseases in variety of settings. For example, the executive summary in the Kidney Disease Improving Global Outcomes Controversy Conference, they use the term kidney supportive care instead of kidney palliative care to help reinforce the appropriateness of this kind of care throughout the symptomatic illness trajectory and distinguish it from end-of-life care. Even Mask in 2019 defined the term supportive care in oncology, where it encompasses everything from adverse events of anti-cancer treatment to end-of-life care. Belfort Mount, as my colleagues have already mentioned before, changed the name to palliative medicine to increase the scope and broaden the horizon for the physicians who were practicing it at that time. And as Dr. Bruera has marvelously said, evolution of our language, for example, from terminally ill to seriously ill, from abuse, aberrant use, or addicts to non-medical opioid use, from narcotics to opioids, from cancer patients to patients with cancer, our words are what reflects our thoughts, and from these come out our actions. So let us just progress. And as we all know, death and change are two great constants in our life. So let us welcome it with open arms and maybe take steps to change them according to what we see best for us instead. And lastly, as my co-CEOs have already previously mentioned, the famous quote, "What is in the name?" But we always remember it as being said by the great William Shakespeare. So isn't it in itself an oxymoron? Thank you.
Dr. Rutula. So now we are all super rich with new concepts and ideas, I guess. So next we have speaker number 7, Dr. Vijayender. Dr. Vijayender will be speaking against name change. Dr. Vijayender, please take over.
Yeah, good. Actually, I'm speaking in support of palliative care. Oops. Good afternoon, all. I start my debate with the famous aphorism of Hippocrates regarding medicine. Cure sometimes, treat often, and comfort always. This aphorism highlights the age of old custom of therapeutics to target alleviating suffering to keep patient comfortable always. This was based on the realization by the doyens of medicine that majority of diseases suffered by the humankind is incurable. However, medicine was always able to successfully relieve suffering to a large extent, which is evidence of palliative care being present since the first human being was attended to and comforted. We know that Cicely Sanders started hospice care from in late 1940s, and she has established a dedicated hospice center in late 1960s. And the term palliative care was formulated around in 1970s by a Canadian doctor, Balfour Mountain, as said by my previous speakers. He set up this palliative care ward when he has set up a hospital ward for taking care of the terminally ill and sick patients. The term has gained good popularity in the UK from the late 1970s, and it has gaining popularity across the world since last 2 to 3 decades. Since in 1990, WHO has recognized defined the term palliative care, and also the American Board of Medical Specialties has recognized the palliative care as a different as a specialty. That WHO defined palliative care as WHO palliative care, and it includes the holistic care of patients and their family members. And palliative care involves the action intended to relieve pain, suffering, which may be the physical, psychological, social in nature. This is including all the things. That means hospice care and supportive care, whatever my previous speakers are saying, this is including those terms also. So this palliative care is a multidisciplinary team of doctors, nurses, psychologists, social workers who work in rhythm to achieve comfort for the patients and their families. Medicine has been shown to either cure illness or protect and help healthy people who are not ill. Palliative care by core definition does not intend or lead to healing. Hence, it shall not be logical to associate palliative as palliative medicine. Rather, the name palliative care optimally recognizes the role of all healthcare teams who are so significantly involved in alleviating suffering. In India also, the name palliative care has gained good popularity in last 2 decades. All the healthcare workers, patients, and the policy makers are well aware of the term palliative care. At this point of time, changing the palliative care may confuse the healthcare workers, patients, and the policy makers. So let's stick to the WHO's 3 pillars of palliative care, that is government policy, education, and availability of the medicines. So it is good to work on these 3 pillars of the palliative care, then changing the name. Hence, I conclude with perception of the palliative care should be changed instead of changing the palliative care, the term itself. Thank you.
Thank you, everyone. Thank you, all the speakers, for such profound deliberation on palliative care, for it to be changed, the name to be changed or not to be changed. And now I would like to call upon Dr. Jyotsna to take some opinions from the speakers, judges, and also the audience on what they think should be an alternative name to palliative care if change is what we perceive it to be. Dr. Jyotsna, please.
I'll just reiterate what Sir has just told. So we just have a few minutes before we close this session. This was a very fantastic session. We all enjoyed it. And we have a final question for all of you guys. This is completely non-judgmental, so just be cool on this. So the question goes like this. If you ever get the power to decide the name of your specialty, what would that name be? I will repeat the question. If you ever get the power to change the name of your specialty, what would that name be? So this is an open question. This is open to all the participants. Participants, please raise your hands if possible. So we'll call you one by one. Also, all those who are in the audience, please put your opinions on the chat as well. So I am opening this forum. Any takers?
Dr. Raghav.
Enhanced supportive care would be my proposition.
Thank you. Super. Next, anybody else?
Yeah. Dr. Kritika.
Palliative medicine and supportive care.
Dr. Prasoon.
Supportive oncology and assuaging medicine.
Sorry, supportive oncology and?
Assuaging medicine.
Wow, that's nice. Dr. Mansi Patil.
Palliative medicine.
Okay. Anyone else in the audience? Anyone else from the judges? Anyone else?
I would just like to say that it was very interesting to hear such viewpoints, and it makes a lot of sense. Some of the points, of course, one has compel you to rethink the name of palliative medicine again. So it wasn't like that the answer was like a writing on the wall. That's all I can say. You could take points from all the participants.
Thank you, madam. Thank you for this.
Sir, Dr. Jyoti Prakash had raised his hand.
Yeah, please, Dr. Jyoti Prakash.
Dr. Jyoti Prakash, please unmute yourself.
Yes.
Yes, I would still say that I support the concept of palliative care because we should aptly said, what we cannot cure, let us care for it.
Thank you, Dr. Jyoti Prakash. Divakaran, sir?
Yeah. When Dr. Barfamount in 1974 coined the term palliative medicine, palliative care, he proved himself to be a poet, apart from an oncosurgeon. Such a poetic term that clearly depicts the scientific analysis. But time has changed and we have moved further forward. And now, what is essentially palliative care? It is the mainstream medicine plus addressing the suffering. That's it. It is mainstream medicine plus addressing the suffering. And addressing the suffering is an ethical mandate of any health professional. So I think it is just appropriate medicine. By what we mean palliative care, it is just appropriate medicine. We can't change the name to appropriate medicine. It has got two advantages. One is that it clearly defines what we are doing. Another thing is that it challenges the mainstream medicine, which forget about the suffering of the patient because of the disease-focused approach. So, of course, the appropriate medicine has no poetic flavor. So we can request Dr. Barfamount himself to coin a new term, which mean appropriate medicine. Thank you.
Thank you so much, sir, for that. We shall definitely have more poets in here. Anyone else, please? From the audience?
Dr. Romana has something to say. Dr. Romana, please go ahead.
First of all, thank you for inviting me to be part of this debate. I've enjoyed thoroughly, and it's definitely innovative point to discuss on. I enjoyed, I would say, I don't have a definite name. Can you hear me?
First of all, thank you for.
You can't hear me?
We can hear you now. Yeah.
Okay. I just wanted to thank you for having me for this debate. Enjoyed listening to all of you. The participants tried and they were excellent in putting across their points. I would say I still like palliative and supportive care together. Makes a lot of sense to me. And how we define it, how it's perceived is important. So the more we talk about what is the scope of palliative medicine, that will give clarity. I think name alone won't really work. It already has a nice name and it's unique. So, but both sides did fantastic. Thank you so much.
Thank you so much, Dr. Dora. It's really indeed an interesting point because it's about the perspective that we need to change and not about the term palliative care. We have 2 more minutes to go. Anyone else would like to put forth anything unique, different?
Anybody from the audience wants to add something?
Since we have no one responding, so what we could do is we could wind up the session. I thank all the debaters for putting all their efforts into this program and bringing up unique features, unique points to this debate. I would also like to thank all our judges for actually voluntarily taking up this task of judging at the most difficult situation. And thank you, the organizing committee, for having this interesting, scintillating discussion today. Thank you so much, everyone. Thank you for your time. Thank you.
Thank you.
It was indeed a wonderful brainstorming sessions, and all the participants did an excellent job. And I'm sure the judges are going to have a tough time, But nevertheless, I think that in this forum, everybody has won. So that's how I look at it. Yeah, it was really phenomenal. It was very, very, very good, each and every participant. God bless you all.
Thank you so much, sir. Thank you.
Thank you.
Thank you, sir.
Thank you all.
Bye. Bye. Bye.
Thank you.
Bye.
This we conclude our session of debate. We now have a break of half an hour. And please, all of you, please be back by 4:30. We have a very important plenary. So we'll be back by 4:30. Thank you.
Thank you very much.